MacMillan agency is especially focused on retirement security, estate planning, and supporting the transitioning of the baby boomer generation. The agency was also spent several years actively working with enrolling and servicing employee group benefits for large and small companies. Mr. MacMillan has enjoyed lifelong involvement and leadership in civic and community activities. He currently chairs the Health Committee of Jacksonville branch of the NAACP, supports holistic health for seniors, sponsored by the Humana Foundation, a multi-year program targeting access to healthy, fresh food and social isolation in Jacksonville Health Zone 1. He is also vice chairman of the board of directors of Mindful Meditation Ministry Incorporated. I'm sorry, I'm getting some things coming on my phone. I'm sorry, I apologize about that. He volunteered for several years as an instructor for Best Academy in Jacksonville. He chaired the Jacksonville Urban League Housing Initiatives program.
Okay, can you hear me? Okay, go ahead.
Yes, I'm sorry, my power is going out of my house. We're having a storm here. So okay. I apologize about that. If it's cutting in and out.
That's okay. We can transition from the intro. We've heard enough about me already.
Okay, I apologize about that.
That's okay. I was experiencing that yesterday in the middle of a transaction, and my internet kept going in and out because we were in a storm. So that is life in the South.
You're right.
Okay. All right, so with that introduction, I'll transition to what we're here to talk about this evening, and that is access to navigating the healthcare system. What I will be specifically addressing is the point of entry to access to health insurance and the payment vehicles for funding healthcare. There'll be subsequent town hall meetings that'll address the process once you enter to receive care and beyond, which is beyond my scope of presentation. So here it's just how do you access the insurance systems and what's available for people as we go forward compared to what it was. As I was introduced, I'm the managing agent of the MacMillan Agency, and hopefully this doesn't come across as a commercial. It's kind of hard for me to discuss this outside my identity of who I am and what I do. But we'll try and give you balanced information and answer the questions that are pertinent for people seeking access to the healthcare system. The first thing is, what is insurance and why do you have it? And it's basically a way of managing risk. The number one cause of bankruptcy is medical bills. So to be hit with a large medical bill, you go to the emergency room and end up with a $3,000, $4,000, $5,000 bill. Even with insurance, you can end up with $1,000 bill. So it's all about limiting the risk, and the way insurance does that is it spreads it out across a lot of people so that everybody pays a little, and the pool pays the bulk of the expenses associated with healthcare. Now, if you get nothing else from this, there are some questions that you want to answer about potentially engaging with the healthcare system in terms of what will it cost me, what will I pay? What will I pay for a primary care physician visit? What will I pay for a specialist visit? What will I experience with my prescription drugs, which can be an enormous amount depending on how many medications you might be on. I see people who take a dozen medications a day, some of them life-saving. And so that becomes pronounced and profound as we get older. What will it cost me if I have to go to the emergency room? What will it cost me for a hospital stay? What will it cost me for a house outpatient procedure? And of course, at the time of seeking services is not when you want to be finding out the answers to these questions and getting big surprises. So we want to prepare you to have no surprises and eliminate the financial risk where we can. We're going to talk about access to the healthcare system in two broad segments, the under 65, and we're going to primarily focus on Obamacare and explain some things about that, and the 65 and up, primarily Medicare, and we will explain some things about that as well. As a footnote, Medicaid, I'm going to ask what's the difference between Medicaid and Medicare. Medicaid is administered by the state, funded by the federal government, but administered state by state, and it is medical care for the poor. Frequently for pregnant women with children over 65 and under a specific level of income. And of course, there's Florida Kids Care for the poor. Kids can get health care paid. So the majority of this discussion is going to focus on the first two bullets and accessing the healthcare system and making sure that you eliminate your financial risk. Now, for ages 65 and plus, Medicare, original Medicare, came about in the Johnson administration. And there's two parts, Medicare A and B. A pays for hospital largely, and B pays for doctor visits and outpatient. Now, there's some things you need to understand. Original Medicare only pays 80%. So the financial risk is how do you handle the other 20%, which, as we discussed, can be a sizable bill. When you turn 65, if you're already on Social Security, you will automatically be enrolled in Medicare's Part A and B. And some people don't qualify immediately for Part B if you don't have 20 quarters of work participation. You, on the surface, are not eligible for Part B, but if you're low enough income, I'll explain how you can still get Parts A and B. So that's the overview, quick overview of Medicare. Now, Medicare original Medicare, Part A and B, do not include prescription drugs. They do not include dental. They do not include vision. They do not include hearing. And you can purchase a Part D prescription drug plan to support your Part A and B. And for the other 20% that A and B doesn't pay for, you can actually purchase a Medicare supplement plan. Originally, option one in the red was the only thing that was available. So to cover that other 20% that Medicare does not cover, you would purchase a Medicare supplement plan, otherwise referred to as Medigap. And that can be as much as in the $200 a month range. And you pick up a prescription drug plan, which can be as much as $20 to $50 a month. And then you've eliminated basically your financial risk associated with healthcare. The problem is a large number of seniors, when they retire and are at this age, don't have $200+ a month for supplemental coverage to supplement and complement their Medicare. And during the Bush administration, the Medicare Advantage plan came along, and that happens to help a lot of people because the Medicare Advantage plan, which over two-thirds of the people now accept at age 65. So that's a large and growing segment. The Medicare Advantage includes the Parts A and B. It's called Part C, but it includes Parts A and B, and usually comes with prescription drug plans and some additional benefits that are thrown in. Now in Florida, most of the plans have zero monthly premium. So you can see the comparison between a column where you could pay hundreds of dollars a month and the column where you pay $0 a month and you have some co-pays at the point of engagement. opens up a lot more of the population to be able to cover that 20% risk factor, because you can imagine 20% of a hospital bill is more than most people can afford to swallow. And this chart just compares, if I go from the right to the left, you got original Medicare, you got the Medicare supplement or Medigap, and you got the Medicare Advantage. Now, hospital stays, they all cover medical, preventive services, they all three cover those. Original Medicare does not pay for prescription drugs, as we discussed. You have to get a prescription drug plan known as Part D. If you get a Medicare supplement, it doesn't cover those, and you have to get a prescription drug plan. Routine visions, not covered under original Medicare, may be covered under some Medicare supplement plans. They're expanding their benefits in many cases to be more competitive. And hearing exam routine, not covered under original Medicare. Medicare supplements may, to some extent today. And then this doesn't show dental, but there's no dental under original Medicare. Typically, there's no dental under a Medicare supplement. And usually there's basic dental, basic hearing, basic vision covered under the Medicare Advantage. So you can see right on the surface where there is our budget concerns and you get the total coverage, you can see why almost 70% of the people are choosing the Medicare Advantage. So why would someone choose this option where it's costing you, hundreds of dollars a month? If you retire knowing you are a heavy consumer of healthcare, for instance, someone who's been treated for cancer and they're in that process, those treatments can be really expensive, and you know that you have the likelihood of several hospital stays, then you might be advantaged. Some people I run into also say, well, I'd rather just, pay the 200 and 200 for my wife and 200 for my, and I know I've got my costs covered and that's budgeted and I don't have to worry about, any co-pays or any such. And for people who retire with the means, that's a reasonable choice. But those are the choices for addressing the risks of the 20% that Medicare does not cover. For the under 65, we have the blessing of Affordable Care Act, which is usually referred to as Obamacare. Fortunately, we've had some expansions of that during the current administration. It's no secret the prior administration sought to destroy or reduce it, but it's just too popular of a program. We have 14 million people now get their health care through affordable care. And for households between 100 and 400% of the federal poverty level, and I'll show you what those numbers actually represent. So someone who's making $12,000 a year, for instance, typically will qualify for a health insurance plan with zero premium based on the subsidy that is a tax credit that is based on your income. So the lower your income, the higher the subsidy that is a tax credit that helps you pay the monthly premiums for your health care, so that people who heretofore would have been locked out of the healthcare system using the emergency room as their primary care, we can get those people to more preventive care so that we can move people to preventive care from chronic and critical care and using the emergency room as their primary care physician. What's required to get affordable care or Obamacare? Live in the United States, citizen, a national, or lawfully present. So you do not have to be a citizen of the country. You have to be lawfully present and working, not incarcerated, and not covered by Medicare. We talked about the federal poverty level. So for 2022, the poverty level is for a single person of one, $13,500 5. And so you can see where if we're going to 400% of that, then a person making over $50,000 as a single person can still qualify for under the marketplace. And of course, for larger families, that number is larger. So that's a new development. Up to 150% of the poverty level can now apply year-round for Obamacare. It's not limited to 2 months of the year, or it was reduced to 1 month of the year in the previous administration. This administration has expanded access and expanded coverage so that we can now cover more people. Now I'm going to talk to you about how you would actually access. If you go to Medicare.gov, and I'm going to show you the government systems, and then I'm going to show you some easier, more friendly alternatives, so it doesn't look like I'm just trying to convince one way or another. Now, this is Medicare.gov. It's got lots of Medicare information. You can log in and create an account. You can go over here where it says Find Plans, and you can then take a look at the plans in your area without necessarily logging in and creating an account, and you can pull up the plans in your area. Now, the thing about Medicare.gov, I'll tell you, when you go in and you enter your prescription drug information to get the budget for what your drugs are going to cost you, it gives out the wrong information. The numbers are not correct. Imagine that, the government site not totally working right. And you can continue without logging in, and you can say, I want, whether you want a Medicare Advantage Part D or Medigap only. I'll click the Medicare Advantage, put in your zip code, put in 32244, and Duval County, and I don't get help from Medicaid. Now, the products are different depending on whether you get Medicaid help or an extra savings program. That'll impact your numbers as well. And continue clicking, and then it'll bring up the plans in your area. There are 42 Medicare Advantage plans. If I clicked on Medicare Supplement, it'd say 4 or 5. And you can look at the star ratings, Medicare rates plans 1 to 5, 5 being the top rating. And you can scroll down, and then you can drill down into each particular plan that way. Okay. The other for Obamacare, healthcare.gov is more, it's a little more cumbersome to navigate. You can see if you can enroll. We're outside of open enrollment. There are special enrollment periods based on events in life, like losing care, moving and relocating, a divorce, adding of a child or family member. Those things can allow you to enroll outside of open enrollment. And as we discussed, if you're under 150% of the poverty level, you can enroll year-round. Okay. Now, here you're going to have to put in a bunch of information before you can actually get information about plans. So that, see if you have a special enrollment period. And you pick what enrollment period you have, and kind of keep going, and eventually you'll pull up some plans. I'm going to show you now. Most agencies like myself will have a mechanism for you to go in and do the same thing. It's a little more user-friendly. Alltherightplans.com is our site. And say, alltherightplans.com. Pop up for Medicare study. And if you want to compare Medicare, yes.
Had a question.
Go ahead.
Uh, on the enrollment period,
Mm-hmm.
did you say that the Biden administration extended that period?
Yes, in the first year they extended it for 6 months.
Uh-huh.
This past year it was 2 months, November and December, and it actually extended into January.
Okay.
And then for if you are under 150% of the federal poverty level, you can enroll year round.
That's great. That's
Okay. So, and my contention has always been, if you really want to take care of people, you don't put limits. You just enroll people as
Right.
far and as many as you can. And it overall lowers the cost of the healthcare system overall,
Exactly.
because you got fewer people using critical care, and of course the old ounce of prevention. Uh, so yes, they have expanded access and affordability. There were, I think, 5 million new people enrolled in the last enrollment period.
Oh, that's
So it is expanding and extending access for folks.
great. And the other question I had was, when you go on the government site and it
Hmm.
lists those plans, are those
Hmm.
commercial plans that the government has reviewed and sort of vetted?
Um, yes, any Medicare Advantage plan has been reviewed and vetted by CMS, Center for Medicare and Medicaid. And so they are operating with a license with the original Medicare, and you receive your health care through the funding of your health care specifically through the insurance company, as opposed to directly dealing with Medicare. And they have contracts with Medicare. And and said, well, how can they do that? Because the government is not in the fundamental business of managing healthcare. So they could say if it's costing the government $1,000 a person, an insurance company can probably do it for 600. And so, and it takes the burden of hiring and retaining more people for this specific purpose, so that all of these carriers, and you can see some household names. You got Aetna, Devoted, you've got United Healthcare, you've got Humana, you've got WellCare, you've got Aetna, you got Florida Blue, WellCare. So these are the healthcare companies in the marketplace. It's just that this Medicare market is a set of products that these insurance companies provide. And when you look at the Obamacare under 65, you'll see, the same thing. It is insurance companies from the market that choose to now contract with this marketplace to provide the coverage.
Thank you very much.
My pleasure. Okay, so on this site, there's also a video that explains everything that I talked about. This one happens to be with United Healthcare. We used to have 4 of them up there from each insurance company, but just kind of got too cluttered having all saying the same things. But it walks through, and you can take your time and take a look at that comparison chart that I had, and it'll walk you through the nuances of Medicare more completely. And if we click on, you can go right in and do basically the same, comparable to Medicare.gov. Just put in the zip code, Duval County, and then it'll bring up the plans in the area, and you can pull. And what I want to show you is an example of taking a look at the budget and what it's going to cost you for your health care in a particular year. Because if you have a number of prescriptions, that can be very important looking from plan to plan, because some plans have different drugs in their formulary, And so, so we're looking at, in my zip code, 33 Medicare Advantage plans, 5 that don't have prescription drugs, 11 standalone prescription drug plans, and 4 Medicare supplement plans. Now, what I'm gonna click the Insulin Savings, because fortunately, most of the plans have come along with a provision to limit the cost of insulin, which could be just an astronomical number, especially for some of the newer insulin, so that they limit them to $35. And you can put in your doctor, enter your doctors, so that you can, know before digging into a plan whether your physician accepts the plan or not. No use in spend a lot of time on a plan that your physician doesn't carry. So I'm going to, by the way of examples, I'm going to, as someone who doesn't receive assistance from Medicaid, and enter some drugs and just show you how, because one of the things that you'll hear is the infamous donut hole. And that donut hole, I should have an illustration, but there's periods where your costs can fluctuate once you've paid X amount for prescription drugs, and then it changes again. And so that's something you want to take a look for. So I'm going to put in amlodipine. Oh, I must spell it. So have your prescriptions out, okay? And we'll add 5 milligrams, and we'll put in a Jardiance, which is a crazy insulin. And you can see if you put in the first few words, you don't have to type in the long name of the drug. Just pick one. I don't even know what that is. Okay. And a Novastatin. Okay. One of those, and add that to the list. And I'm going to add Novolog. See what it does to the numbers. Okay. Okay, so we got the drugs in, and okay, and then we'll go and see what the prescription drug costs will look like under one plan or another. Okay, pick the pharmacy, and we won't bother putting in a doctor, but you can put in your doctor, and it'll tell you immediately if your doctor accepts the plan or not. Okay. So now let's take a look at and we'll sort by plan premium. Okay. Okay, so you can see these estimated costs for the year with those drugs. Now, some of those are combinations you would never have put together, but I just wanted to, for illustration purposes. And okay, and you can click through on any plan and pull up the details on the plan. And you could actually enroll yourself if you don't want to talk to an insurance man or person. But with any of these health plans, it doesn't cost you anything to be assisted. There are also volunteers, navigators who are nonprofits who are available to help folks. And so there's various agencies. I would advise getting some help because it doesn't cost you anything, whether you use an agent or whether you use a volunteer. I would advise getting some help. Okay. And so it tells you, now let's take a look at these prescriptions. The amlodipine is covered, the Complera is covered, the azitamib is not covered, Jardiance is covered, Novolog, and that's one of the things you want to make sure, especially for people on insulin, make sure that your insulin is on the list for that particular carrier versus one that might be. These are two different types of insulin, probably wouldn't see them in the same patient, but I entered those for that purpose so that we can, and you can go back and edit your list if you forgot something or you put something in you need to add something in, and you can go back and take a look. Then let's take a look at the total estimated costs, okay, on a month-by-month basis. So you can see when your costs change on a month-by-month basis, when you go into the infamous donut hole and come out of it. So based on those drugs that I input, it'll tell you how much each one of them will cost per month, okay? So that if there's something, if we switch to another plan and to take a look, then we would look at what those costs look like under that particular plan so that you can take a look at what your experience will be for any particular plan. And you can compare, and I won't go through all the comparisons of putting them side by side, but you can compare 3 or 4 plans side by side. And so that's on the Medicare side. The same thing on the Affordable Care side. Now, if you go to it on this side, it's going to be a lot more user-friendly than healthcare.gov. You've got to go through a lot of screens before you actually get the information you want. Here you put in your zip code and you're going to have to put in your age and income, and then you can look at plans. Okay. So we're in Duval. Continue. Now we've left the Medicare side. Now we're on the under 65. Let's say a 55-year-old male that's single. We won't add a spouse, but you could add a spouse. And let's say household income is 35,000. Single male. Okay, so what that tells you, without having to go through a whole bunch of steps, is that that person with that age and income is eligible for a subsidy of $624 a month to help pay for his healthcare premiums. Okay, and that means you'll have plans as low as $0 per month. All right, and let's see. Okay. Again, we can enter the name of the doctor and it can tell you if the doctor, I'm going to put Floyd Willis in here. Okay. And again, you can enter your prescription drugs. And so we'll skip that step for this one. And then it's going to show you the plans. Now we only have 144 plans available, okay? These are sorted by lowest premium, sorted by lowest deductible, which is a more telling number, okay? So with zero deductible. My lowest cost plan with zero deductible is $59 a month. Okay. And you can see what doctor's visits and specialist visits and generic drugs. He's going to show up not taking most plans. For instance, he's at, and because he's at Mayo. And so you can go from there and you can look at the combinations and you can drill down and look at the plan details, but I'm going to resort these by lowest premium. So you can start with the zero monthly cost, because most people who don't have insurance are going to be concerned with the monthly premium, but you also want to be concerned with the number. Like for this one, it's zero premium, but you got to satisfy the deductible, which is a large amount, and then it's $35 for the doctor. So if you got to satisfy that deductible before you can go to the doctor, it's kind of moot. This next plan, it happens to be a Florida Blue plan. It's got $0, but the doctor visits are free and the specialist visits are free, and you still got to satisfy your deductible for your medications. So as you go down, you really want to take a look at what these doctor's visits and specialist visits and the drugs cost, as well as the monthly premium, so that you've got a plan that you can actually utilize. Now, let's take a look at this one. It's $11 a month, $8,300 deductible, but your doctor's visits are 40, specialist visits and your generic drugs are 27. That's not having to satisfy the deductible. You know, you've got those predictable costs. And so as we take a look at what your specific needs are, then we can resort these based on what really fits your needs, okay? And like I said, there's 133 of them. So based on what a person's need was, then we'd take a look at where and how we drill down. But again, you can take any plan and you can drill down and take a look at the details, summary of benefits, which is a document that gives you more details on the coverage. You can pull it up, read it for yourself, study it, take it to the doctor and make sure that, before you sign up, that you've got the details associated with the coverage that you're looking at. Okay.
So Jerry,
yes, sir.
I had a question about
okay.
the deductible. Is that talking about the drug costs?
No, that's the healthcare costs. Some plans will have a prescription deductible.
Mm-hmm.
Okay, so the deductible is for the costs of providers. You pay, generally you must pay all the costs from providers up to the deductible amount before this plan begins to pay. Okay, and then if there are other deductibles, like for a prescription drug, are there other deductibles or for a specific service? It would show here if there was a deductible for prescription drugs. So it does not have a deductible for prescription drugs on this particular plan. It's just a medical deductible. And it'll give you some examples of, whether it's an in-network, non-participating, out-of-network, no coverage at all. And it'll give you examples of what you will pay for each type of tests, physician's visits. And then there's a more detailed document that's an evidence of coverage that goes into more detail. But you want to understand, like the first chart, what will it cost if I, have an outpatient procedure, an inpatient procedure, as you're looking at the plan, so that you can get an idea of exactly what your costs would be in the event of certain occurrences.
So,
okay.
so in a way, if I look at it, let's say it's $8,000 deductible. You divide that by 12. You're somewhere south of 800 a month, 700 a month, which may be typical for an individual in the workplace anyway.
If you were playing, marketplace, with this person, he's got a $600 something subsidy. So yeah, it'd be about $700 a month if you were to buy the plan on your own. But now the deductible, I wouldn't look at it that way. The deductible is based on occurrences. So The things that would cause you to use a deductible is if you you got sick and had to go to the hospital. Okay. And so, basically yourself at risk for $6,100 before the plan starts to take over. And now again, you're just going to the doctor, all of your preventive care is zero. So regardless of what plan you have, you're go and get your checkups, that's zero cost, always, under all the plans. You get sick and go to the doctor under this particular plan, it's a $35. And here it says here, preventive care visit free, before or after deductible. Specialist visit before deductible, full price, after deductible. Okay, so that lets you know, it's a zero premium, but probably not giving us the financial protection that we want to have. Okay,
Right.
So okay, so then if we go back and we take a look, that's why I like to sort it by lowest deductible, because that way you're managing your overall exposure. Here I got $59 a month, but I got zero deductible. Okay, so you talk about that, $6,100 or that $6,100 is here at zero. So you're paying $60 a month, but you don't have the financial exposure beyond that. Okay, and you know what your predictable costs are. Okay, similarly, $90 a month and doctors. So, if I had a condition and my doctor is in, Bright Health, like for instance, I had a client who her nurse practitioner was at UF Health and she was in network with Bright Health. So if you got a zero deductible, free doctor visits, $90 a month, especially, if you have some health issues and zero mental health, zero prescription drugs, zero telehealth. So, you get sick in the middle of the night, you can cause, and I actually used telehealth last year during COVID, and first time I'd use it, and it worked out very well. By the time I got on FaceTime with him, he had my medical records in hand, and he looked at me and said, "Yep, your face is swollen. Yep, okay, let's take care of it." So yeah, that would be a very reasonable plan for someone who had no coverage and is making $30,000 a year. At 55 years old, we begin to realize our mortality and morbidity. So these investments become more reasonable. So you want to look for a low deductible with a manageable monthly premium and predictable costs. All right, and you can continue to drill down and see, if you got several specialists, you can put all three of them in and see which plan all three of your doctors accept. That way you can do your homework, and you can do this on your own, or you can call and we can walk you through it. Okay.
Very helpful. Thank you.
All right. So any questions on doing your homework and understanding what your costs will be with either Medicare or with Obamacare, Affordable Care Act? Okay. So again, you can access both of those at alltherightplans.com, which is actually is the site for my agency. And okay, let's see, the contact information was one of the questions. Feel free to contact me at any time. Actually, and if you go to the site, at the top of it, there is a link to schedule a time right on my calendar, so you can get yourself right onto my calendar if you want to talk. Okay. All right. So we've talked about Medicare and its access. We've talked about Obamacare and its access. We talked about the fact that a single person earning under $20,000 a year, which might be your landscaper, might be a construction worker, might be a part-time worker who has no health care, can probably get a plan with zero monthly premium, go get their checkups, go get their preventive care, be able to get medications, be able to get telehealth rather than going to the emergency room in the middle of the night. And so that becomes pretty meaningful. Okay. So in addition, there are ancillary, like anybody can buy a standalone dental plan, a standalone vision plan. You can purchase a Medicare indemnity, or called hospital indemnity. And what that does is, because there are co-pays associated with insurance and deductibles, what the medical indemnity, you can purchase that. Say, if I go to the emergency room, or if I go to the admitted in the hospital, then it'll pay me X amount of money that I can use for my deductibles, or I can use for my co-pays, or I could use it to buy myself a bunch of nice sweaters. It's your money. If you have an occurrence, they're going to pay the money directly to you. I mean, you've seen the duck commercials, right? So those are indemnity products that pay directly to you in the event of an occurrence, usually an emergency room visit or a hospital stay. That's where you have the financial exposure through the healthcare system. And I deal with clients from other countries. I had a client from Germany, and she said, people pay $1,000 a month for health insurance. I assure you they do. In those countries, healthcare is a right of citizenship. They just go to the doctor. It's included in their taxes. And so, people come from other countries and they just don't have a concept for the idea of healthcare being reserved for those who can pay. You can get a cancer policy that pays you, cash in the event of diagnosis. I saw a scary statistic that said 1 out of 2 women and 1 out of 3 men, I may be flip-flopping those, will have an occurrence of cancer. That was a startling statistic. So I increased my cancer policy. I used to say, I don't need that junk. But now that I have salt and pepper, more salt and pepper, then these things become a little more real. Critical illness, you can, again, because when you're engaged with the healthcare system with a diagnosis like cancer or heart attack or stroke, they start nickel and diming you to death. It's hard to get well when you're getting all these medical bills that you weren't expecting to get. So there are policies that in the event of those instances, they'll pay you a lump sum, and then that money can be used to offset some of those expenses, may have more time off from work. So those are things to consider whenever looking at, policies of any type. Is a combination of what are my needs, what's my budget, and how can I balance that in a way that makes the most sense for my particular situation. The answer is different for each person. And that's basically what I wanted to cover this evening with respect to access and insurance and how you set yourself up to make sure that you can, because there's a real difference between going to an emergency room with insurance and without it. You go in an emergency room without it, they have a legal obligation to get you patched up and get you out of there. You go in with insurance, they have a financial incentive to make sure you got everything that can possibly fix you. With that, I'll open it up to if we have any additional questions.
Jerry, I had a question. From your experience, having done this for many years, how has this the public policy that we've had, and I understand that it's had ups and downs and starts and poor and bad starts because of politics and the like, and I imagine the time it's taken for the commercial aspects of this to be figured out by the companies. But how do you see it now in terms of its covering people's needs, and what other things might be fixed, short of course going to a public healthcare system?
Right.
What other things might be added that that would significantly improve the
Uh,
availability of health care for all?
I think that the one thing is there's one hole or gap, which is the spousal gap. If your spouse has access to a group plan, then you cannot access uh, the healthcare system through affordable care. You must participate in and the spouse's plan is almost always going to be more expensive and in some cases not as good. I mean, some employers have absolutely horrible employee health care policies available at absolute minimum necessary to keep them out of trouble. And I won't call any company names, but there are some that I just stopped doing their employee enrollments because the care was so poor that I couldn't sit there and talk to people about it with a straight face. But that gap where a spouse must go with their spouse's plan and not access affordable care, regardless of the household income, is a gap that needs to close. Um, and I've seen when spouse go to work and household cost of health insurance went up by $400. Nothing changed except she got a job and now they got to take her plan. Um, there, otherwise, I think it does. I mean, it meets a tremendous need. I think if anything, figuring out how the companies can cover more of the financial risk as we look down at those categories of occurrences, um, because not everyone can afford an indemnity plan to help with the copays. So if we can continue to get the copays and deductibles down and continue to limit the individual and family risk, that would be represented improvement. But it's a tremendous leap forward. I mean, I think it's one of the innovations of the century. When the history of the century is written, will be the Affordable Care Act. We just have to make sure that we continue to strengthen again the benefits and understand how we'll continue to lower the cost of the healthcare system so that that can be done without breaking the bank.
Thank you. And a follow-up is from your view of the business world that is involved in healthcare as an interface for the individual. And this, I'm asking you to be more neutral and put your advocacy hat on,
Mm-hmm.
because after all, you are with the NAACP and have worked with the Urban League for a long time as well. What advocacy can we do to ensure that people are being treated well by the people that like yourself, who hold themselves out as providers, as assistants to access to care? Are there issues there that need to be addressed? And there's a follow-up question: is from the medical side, what things should be addressed to ensure that people are being fairly treated? So, just on the first question,
How do we hold people like myself accountable?
right? Yeah, yeah.
I'd say surveying the community. We participated in as you know, survey of the transportation services and how well it serves the seniors. We can do sampling. We can hold town halls once we're back to in person. Specifically, the senior resident centers, for instance, and I think we'll, it's the people who can least afford and have the least access to vehicles to make their voices heard, are the places that I would sense as to the perception of how they're treated. Are they happy? Because not all agents, not all volunteer advocates are created equal. Just like not all healthcare providers on the delivery side are created equal. But I think, for instance, like a Urban League or a NAAC Health Committee can do an annual survey where they hit specific portions of the community. They can do annual canvassing and ask specifically in a geographic area to get a feel. So, and making sure that people know that we're here to help. So if you have an issue with unprofessionalism or promises not kept, then do they know that we're here? For the NAACP complaint line, for instance, do they know that there's an NAACP complaint line that they can for social justice, healthcare injustice? So I think making it aware that there are advocates available, and that's one of our objectives with the health committee, is to promote and make people aware that we are here for that purpose.
Very good. And on the medical side, we're just about to 7 o'clock. We always like to end these on time, but from the perspective of the medical side, are the things that you've seen in the last couple of years that ought to be addressed, either through government regulation or otherwise?
It's not all healthcare delivery locations are created equal. And so I think there is room for addressing, why some give better quality than others. And is it a function of purely economics? Do the poor people always get poor care? I think there's a lot of room for examination of relative. For instance, the Medicare plans are rated every year, and they get re-rated every year with a star rating, 1 to 5. Maybe Medicare should be rating providers that same way, based on patient feedback, based on results, based on cost. I think CMS is in a position to do that and has the teeth, since they're paying the bills, to not only make that assessment happen, but also give it some strength behind it. So I think I would probably, on that side, it probably would have to come from CMS, but a rating system driven. Now, many of the carriers on their sites will have a rating for each provider based on how many people have given feedback. I'll just say, like, I know United Healthcare, when you pull up one of their providers, it'll show how many people gave them a rating and what kind of rating they gave, so that I can look and say, well, this person has 29 ratings and they're all really good, or this person only has 2, so there's not a lot of ratings here to go on. So continuing to encourage those types of things, I think, would continue to guard the consumer's health and quality of delivery. We also have a question here. Say, isn't it permissible that government programs, if an employee pays more than 5% of gross income and monthly premium, they're allowed ACA coverage? Thank you for that question. The number is just a little under 10%. And it's kind of tricky also, because if their lowest cost plan is more than 10% of the individual's pay, then they can. So, so technically, if you took the family coverage and applied that, it would probably almost be, qualify. So, but yes, there is a provision. If you have a high cost plan, thank you for making that point. If you have a high cost plan, there's a possibility that you can still get the affordable care. And I do have a client who we managed to make that happen for. So thank you very much for that question.
Right. Any other questions for Jerry? Well, I wanted to thank everybody who attended, and LaQuentia Telfair for arranging this with Jerry. And Jerry, thank you so much for your contribution and all of your contributions that you have made to help our community in your profession for so many years. We're very grateful. Also wanted to recognize Aubrey Gerhardt, another one of our interns who's done a lot of work in our mental health for youth of color. And we've got another town hall on that coming up, so pay attention to our social media on that. But again, thank you so much on behalf of the Jacksonville Urban League Center for Advocacy and Social Justice. Jerry, really appreciate your being with us.
My pleasure. Thank you for inviting me.
And the last person I'd recognize is Deborah Thompson, who's with both the Urban League and the NAACP, and always a great supporter.
Great job, Dennis and Jerry.
All right, well, let your friends know about this, because it is going to be available on our YouTube channel, and we'll be sending the link around. Again, thanks everyone. Thank you, Jerry, and have a great evening and a great rest of the week.